Good afternoon, everybody. We're going to get started, and the speakers are going to promise us they're going to be on time. So it is a pleasure and honor next to the president of the Neurocritical Society to moderate this session with Susan, and I'm going to introduce the first speaker. It's going to be the session is going to be about neurologic complications of systemic illnesses and critical illness. And the first speaker is a dear friend and colleague at Harvard, Dr. Saif Ezzi. He's an assistant professor of neurology and critical care in Harvard Medical School and the Division of Critical Care, and he's the head of immunology and of brain injury program, very active in research. And if you ever sit for the board for neurocritical care, I highly advise his 2 books, or version 2 of his book now. So Saif will be talking to us about management and prognosis of septic encephalopathy. The floor is yours. Saif, close.
Let me see.
Yeah.
Yeah, that's all right. Can you hear me now?
Yes.
I think that's better. Okay. So the talk today will be focused toward septic encephalopathy. I have no financial disclosure related to this topic. And the next 20 minutes, I'll try to go through the definition of septic encephalopathy, walking you through some of the physiology of this disease, touching on the spectrum of clinical diagnosis approach, diagnostic approach, and management principles. The topic of septic encephalopathy is one of the topics that have not very clear definition, except for it's a systemic inflammatory response and systemic infection that lead into cerebral dysfunction, leading to septic encephalopathy. So one of the criteria to diagnose this disease, mostly related, that we have to make sure there is no direct CNS infection, there is no clear structural brain abnormality that could be causing the encephalopathy. In addition, that there is no profound other systemic, hepatic or renal related encephalopathy by clinical testing. So in a bottom line, it's a diagnosis of exclusion. The pathophysiology of this disease related to the systemic immune response. When that storm of cytokines hit the brain, that would typically lead into disruption in the blood-brain barrier, endovascular and endothelial dysfunction, leading to a leaky inflammatory fluid that activate the immune response and in general lead into microglial activation, neurotransmitter imbalance, as well as neuronal hypoxia and toxicity. So it's a very complex cascade of events, mostly related to the underlying etiology, which is the inflammatory response. The epidemiology of this disease and how often we see it, it's very vague and not clearly defined. There are many studies that pointed to 4%, some others 20%. You can go in the literature and find up to 70%. Most of the studies had no clear definition that really standardized between the studies, because the definition itself, it's a diagnosis of exclusion, so it depends on the window of detecting the disease. Some patients might have not developed septic shock physiology or symptoms of infection related, and they still might be delirious or confused. So are we really missing the window of diagnosis? And some of them, they developed it based on what I have shown here, the infection followed by sepsis symptoms. Then there is a window for identifying the symptoms, delirium, confusion, and many others, or seizures, or astraxis. So that's the typical one. But most of these studies are problematic. So that comes into, hopefully by the end of this talk, we can find a way to systemically trying to identify the disease using some of the tools that I will mention. So in terms of a clinical presentation, it's a very wide spectrum of symptoms. It's not only about delirium. The disease could also present with hyperventilation with one of the early signs, rigidity, seizures, autonomic dysfunction, and some of the advanced spectrum of the disease could lead into a coma and also polyneuropathy. And you can see some of the symptoms actually could be localized into specific areas of the brain, as sickness behavior could be localized to the limbic system and amygdala, while the delirium with the frontal and hippocampus, and leading to the more advanced disease with the involvement of the hippocampus and brainstem. And why this is important for the timely identification of these symptoms and the start of the management, because the chronic activation of these areas in the brain could lead to chronic outcomes, including psychological, anxiety, depression, as well as cognitive decline, and mostly, the most devastating one is coma and death. Now, how can we identify patients at risk? So in this nice review by Sonelli et al., really put together multiple studies that have been sporadic in the literature in a very nice table, where we can look into modifiable and non-modifiable. So if we start with non-modifiable, patients who are elderly, with a chronic kidney disease, with liver disease, alcohol abuse, cognitive impairment, on a chronic use of psychoactive drugs, who are critically ill. Septic encephalopathy is the disease of critically ill patients. So patients who are admitted to the ICU on mechanical ventilator, who has a bacteremia, Staph aureus, these are the ones that we should pay attention to and try to identify whether they are in septic encephalopathy. And some other modifiable ones include the low sodium, very high sodium, low glucose, very high glucose, and also the ones with uncontrolled blood pressure. Some of the neurotoxins related effects of cefepime should be also identified. Versed or midazolam is one of the sedatives that correlates with septic encephalopathy in the literature, and we're going to touch into that. So at least now we know who we should screen for this disease. Now, if we have in our ICU or other medical ICU or SICU, when we get consulted in some of these patients, if we have patients who is febrile, delirious, or comatose, the next question in our mind, is there any underlying infection? If the answer is no, as intensivists, when we take care of these patients or we consulted on these patients, we have to expand our workup looking for other reasons for altered mental status. Could be thyroid storm, malignant hyperthermia, neuroleptic malignant syndrome, and others, including central fevers or some underlying pancreatitis or seizure and so forth. So that's just to give you an idea that we have to expand the workup. However, if there is possible underlying infection, we have to think about, is it a CNS-involved disease? If it is, well, by doing a lumbar puncture and ruling out CNS infection, if it is CNS infection, we have to go to treat the CNS infection. However, if the answer is no and no, then that's when septic encephalopathy should come into the top of our differential. What are the tools that we need to further assess the disease? First, the assessment of mental status in general. There are several tools, including GCS. The lower the GCS correlate with the severity of the disease. Other tools, MoCA, to look for the cognitive aspect. MoCA less than 26 has been correlated in the literature with the septic encephalopathy. I know some of them are non-specific, but they are all tools that we have to think about using to further characterize the mental status and the cognitive decline in general. The RAS, whether the RAS is above 1 or below -1, could indicate an underlying delirium. In addition to CAM ICU, which is some of the assessment tools that we use in our ICUs, could also be useful to identify and further characterize mental status. Some of the other tools where we suspect the septic encephalopathy comes into hand when we have to rule out seizures, EEG, look for any structural abnormality using CT scans, MRIs, and also some other advanced tools that has been limited reliability in terms of testing the disease, including TCD, to look for vasospasm or MRI SPEC or even functional MRI. I'll touch on that in the next few slides. So first, if we look at the most commonly used test for assessing the disease. First, we want to rule out if there is any underlying seizure or other prognostic factor. And this nice summarization of the literature in this cartoon, you can see that patients with suspected septic encephalopathy, they have different patterns of EEG presentation. Where slowing, including theta and delta slowing, the top two are most commonly up to 50 to 60% of patients. And they have some prognostication impact where we have to look at. If the patient have persistent slowing in their EEGs despite addressing all underlying potential confounders, then that could be correlating with some intermediate into mortality and long-term delirium. Other pattern of EEG that we have to pay attention to, the suppression, the discontinuity and burst suppression, especially if the patient is sedated. That's why one of the key aspects to further assess disease, trying to minimize sedation or stop sedation on these patients. One of the most common patterns seen in septic encephalopathy, the presence of triphasic waves, and in some patients we see epileptiform discharges, which could lead into possible underlying seizures and long-term epilepsy. So looking into that and categorizing our patient based on EEG is a key for further assessment. Biomarker, unfortunately, there is no current reliable biomarker to tell if there is underlying septic encephalopathy. There are some suggested ones in the literature, including NSE, S100B, which could indicate possible underlying neuronal and glial activation that could be released in the brain and goes through the leaky blood-brain barrier to the blood. Others, including NT-proCMP, neurofilaments. Most recently, the literature with a very small number of patients indicating the potential role of S100AB and MPP8, in addition to some elevation in microRNA, 370 and 155. Again, all the literature is based on a very small number of patients. In terms of imaging, one of the tools that when we get consulted or even see these patients in our unit, think about ruling out any structural abnormality. Having a leaky blood-brain barrier remind us all of other CNS pathology, just like PRES or RCVS, where we see signs of involvement of multiple areas in the brain. Some of that include the presence of edema, ischemia, leukoencephalopathy. There are different presentations based on the literature, but here you can see a very clear, most common presentation of periventricular hyperintensity white matter. And this 79-year-old patient with a history of urosepsis presenting with encephalopathy, and you can see clear presentation. Is that all? Can we use any other potential MRIs to assess that? And this very nice summarization of the literature here, I can show you there are other tools. Depends if it's available in your institution or not, including MR SPECT, where we look into the ratio of N-acetylcysteine and choline and creatinine, which is a reflective and could be a representation of neuronal apoptosis. The ratio of NNA and choline ratio and also creatinine and choline, the decrease in that ratio could correlate with underlying septic encephalopathy based on small studies. Molecular MRI by using anti-DAPO, which is a ligand for reactive oxygen species. Recently became available in our institution. Increased reactive oxygen species could be correlating also with a small number of studies. DWI, ADC, always ask for them when you order these MRIs to look for underlying stroke and involvement of and dysfunction of blood-brain barrier, where you can see signs of vasogenic edema. Flare changes, as the case I just showed you, could be also informative. Very rarely, and we have used it only once in our patient, is the arterial spin labeling to look for the integrity of the blood vessels, which could be also impacted due to the endothelial damage. That depends on the stage of the disease, whether that was done in the early or late sepsis. So these are all tools with limited literature, but could be available to answer some of these questions. Now, if we're able to clearly exclude the co-founders and we're able to identify that this patient meets the definition of septic encephalopathy, how can we manage it? It has to be multidisciplinary, multimodal approach. First starts with identifying the disease on timely manner, rolling out seizures using an EEG, and also to detect other patterns of interest, and also try to manage any underlying hepatic or renal, which could also confound the disease. Most importantly, we have to think about the medications. If there is a cefepime, we have to stop it. We have to minimize the use of Versed because both of them could lead into neurotoxic effect in this disease. In addition to that, as a neurointensivist, we have to make sure to pay attention to the sodium, glucose, and CO2. As intensivists in general, we would love to see numbers, and this some numbers for guidance. For MAP, preferred range is 65 to 80. The same approach that we use for other blood-brain barrier diseases where we don't want hypotension and we don't want over a hypertension spectrum because that could correlate with increased risk of bleeding. Also, studies that looked into higher MAP rate did not show association with improvement in mortality, and there is one study that showed higher MAP associated with higher RAS score. We don't want the oxygenation to be too low. And also some studies look to have higher oxygen rate above 120, but that did not associate, actually increase the risk of septic associated encephalopathy. Avoid fevers because that associated with increased mortality. Avoid hypo and hyperglycemia since that also associated with increased risk of septic encephalopathy. Finally, some studies looked into increasing the hemoglobin with the hope to increase the oxygen supply to the brain with above 9, but that did not correlate with reduced mortality in this disease. So this can give us some targets to available to guide our decisions while we manage this disease. Now, we talked about the initial presentation. What about if we miss the window? We don't treat provide the supportive management, then we have to think about the long-term complication of this disease. If we miss the window and we don't provide this, the multimodal approach supportive therapy, that could correlate with long-term mortality, cognitive impairment, in addition to neuropsychiatric with a long term of depression, anxiety, and patient who develop epilepsy and mismanaged could also develop an epilepsy going forward, in addition to the brain atrophy. So the future direction should be targeted toward a role of biomarkers since it's a disease that involves the immune system. So there are many approaches to try to target CSF and blood advanced biomarker, and that should be based on a large multi-center studies. Of course, it's going to come with limitation, but attempts in that direction could be helpful. Novel therapies to try to modulate and stabilize the blood-brain barrier, and also work on modulating the inflammatory response in the right manner. Using, since EMR now linked with a lot of data, trying to build an AI platform or early detection platform basing on all what we just talked about, from labs into symptoms, and try to have an early detection in our systems. In conclusion, septic encephalopathy is a very complex condition. Timely identification of the disease is really a key aspect of treatment. Providing supportive care in a multimodal approach is the right way to go. And there is always need for more research to identify biomarkers that could help our decision. Thank you so much for listening.
Thank you, Saif. And we'll leave the questions till the end in the discussion, and I urge everybody to stick around till the end of the full session. We will have a great discussion, especially in the presence of a lot of key leaders in the field, so stick around. For the next speaker.
We'd like to welcome the next speaker, Dr. Ryan Hakimi. He's a neurointensivist, director of TCD services at Prisma Health, upstate, and a professor at the Department of Medicine at UCSF USC School of Medicine in Greenville. He's the president-elect of the American Society of Neuroimaging and Neuroimaging Section Chair, and part of the American Academy of Neurology. Please join me in welcoming Dr. Hakimi.
All right, good afternoon. Thank you for this wonderful opportunity. I've been having a really great time here. Haven't been to the Gulf area for over 40 years, and since our family left Iran back in the early 80s. So today I'm going to talk to you about complications of neurosurgical procedures, My disclosures are that I love neuroimaging, and so you're going to be seeing imaging incorporated into teaching cases. So in terms of background, so here, I'm a very simplistic person. I try to divide things into groups and then think within subsets within those groups. So neurosurgical complications are a function of the pathology, the patient, and the operator. So when we think of pathology, there's certain pathology that's very benign, some very small, high convexity meningioma, which is not causing any edema or mass effect or things like that. The excision of that is relatively low risk in comparison to some arteriovenous malformation with an intranidal aneurysm, for example. Patient factors, so uncontrolled hypertension, uncontrolled diabetes, obesity, and so on and so forth. And so optimizing these patients, and both pre-procedurally and during the procedure, which is very often through the anesthesia pre-op clinic and those types of things, is quite important. And then the procedural skill is often dependent on advanced training and experience. So again, thinking in a very simplistic way, I think of open procedures in terms of common neurosurgical complications or neurologic complications, or endovascular procedures. So open procedures, probably more common to have seizures or cerebral edema or some form of intracranial hemorrhage, infection, so on and so forth. Endovascular procedures, there's procedures associated with the vascular access, dissection, hematoma, vasospasm, ischemia, and such. So here in this image here, let me turn on the pointer. So this is a patient just a couple weeks ago we were taking care of, and the patient goes for a mechanical thrombectomy, and they have this procedural complication because they have pretty significant vascular disease. And what you're seeing here is that the person has a vascular occlusion here of their femoral artery. Distally, primarily the popliteal. And then here's a different patient. This person had a dissection as a result of that. These are two different patients. So we'll use some cases. I always like cases because they involve pictures, and I love images, so that's why I think it's useful to use this opportunity. So right MCA occlusions, status post-mechanical thrombectomy. So this is a 65-year-old with atrial fibrillation, and as I like to write in the chart sometimes, intermittently compliant with apixaban. Obviously they come in with a right MCA stroke. They have MER with TICI2C recanalization. And unfortunately, they end up with hemorrhagic transformation. So you see here, this is the ischemic burden, a relatively large stroke despite your procedure. This was the original CTA, which showed the MCA cutoff. Here, there's hemorrhagic transformation. So on T2 star or SWI or gradient recall echo, hypointensity correlates with hemorrhage or calcium. In this case, it's hemorrhage, and you see some hemorrhage within the stroke bed there. However, the person makes it through the process, and they overall their stroke burden is not as bad as one would expect. Here you see that the person ultimately ends up with medical complications of atelectasis, and perhaps a little bit difficult for you to see there, they have really terrible periprocedural hyperglycemia, which we know contributes to cerebral edema, and so putting those patients on an insulin infusion is quite important. So here's another case. This is an open case, so this is a post-tumor resection, and this person unfortunately ended up with an empyema. So 33-year-old comes in. You know, everything that comes to the hospital is a stroke alert nowadays, because there's such a diligence that you know, even if somebody has numbness and tingling of 2 weeks duration, it's stroke alert. So 33-year-old man comes in with weakness and numbness. He gets a stroke alert, and as soon as they see this CAT scan here, you see there's a hyperdensity right here. Okay, that's an interesting sound. The CT scan has this hyperdense mass, so the stroke team says, not it, and they call you. Here we see on MRI there's a contrast enhancement around the mass. It's a dural-based lesion. So the person goes for a craniotomy, and so the craniotomy, the pathology comes back as melanoma. So we all know melanoma is a terrible disease and has a high predilection for returning, and it also has a high predilection for hemorrhage. So patient goes home, and unfortunately, in a couple of weeks later, comes in confused with a fever, and they re-MRI the patient. And here on FLAIR, FLAIR is very good for looking at intraparenchymal edema. So I've highlighted it here for you. You see there's some edema around the lesion site, and in particular there. And they end up with, they do the craniotomy, take them back to the OR, and unfortunately the person has CNS infection. Fortunately, they had a good surgical outcome, started on antibiotics and such. So open procedures, unfortunately infection is a little bit higher on your list. Here's another one, another stroke alert, mind you. 60-year-old male that was assaulted comes in as a stroke alert. And they identify this acute subdural hematoma with brain compression here in your CAT scan. And of course, they call the neuro ICU. So patient goes urgently for surgery because you can see that there's a pretty reasonable amount of brain compression here. And they come back, and postoperative pneumocephalus is very, very common. And you just have to be patient with those folks. Now, of course, the neurosurgeons love to put them on high-flow oxygen, which I don't necessarily think is helpful, but it can be very deleterious if your patient has significant COPD. So that's really where you have to be paying attention. So if your patient has significant COPD and you put them on a non-rebreather mask for hours on end, they're probably going to end up with respiratory failure, so be careful of that. So again, patient goes home and comes back as yet another stroke alert 2 months later, and this is the CAT scan. And unfortunately, this person also developed an infection, and here you see on gadolinium, there's some gadolinium enhancement of the area that's consistent with an empyema, and they go for, in this case, a craniectomy. They leave the bone flap off, and they get admitted to the neuro ICU and end up doing very well. So we can't escape a discussion with somebody who loves TCD without having a discussion about TCD and vasospasm. So this is a really complicated case, but I thought it had a lot of cool images, so I thought I'd show them to you. 45-year-old female in a motor vehicle collision. You know, these are the chicken or the egg kind of things. When the person comes in, they come in as a trauma, low velocity, motor vehicle collision. Which came first? Is this a neurologic injury that caused them to crash their car? Did the car, the impact caused them to have a hemorrhage? Well, this pattern, as you see, we used to call this the crab of death when I was in training. This pattern of injury is not consistent with the trauma. So the trauma team calls and says, not it, and neuro ICU team, come on down. So, so you get a CTA on this person, and they have a left ICA intracranial aneurysm. And because of the morphology of the aneurysm, they were treated with a pipeline device. So pipeline device requires you to be on dual antiplatelets. So now you have somebody with a hemorrhage, then you have to put them on dual antiplatelets. So naturally, you're going to have to pay very close attention to their neurologic exam and the time of administration of their drugs to make sure that they don't get inappropriate double dosing, for example, because they come in at night and those types of things. So here, what I'm trying to show you in this image, so that's the pipeline device there. You see that they've reconstructed the internal carotid artery, and unfortunately, there's some residual aneurysm here on the outer edge there. So they're cruising along in their medical care and unfortunately they developed obstructive hydrocephalus. So here you see transependymal CSF flow, which is represented by this blurring of the ependymal layer in conjunction with the parenchyma. And you see that the third ventricle is dilated. In a 45-year-old, this is a very abnormal CT scan. So they have obstructive hydrocephalus. You got your patient on dual antiplatelets, and you say, okay, well, we need an EVD. Of course, the surgeons are not very excited to put an EVD on somebody on dual antiplatelets. So, this is completely off-label. We put the patient on eptifibatide integralin infusion because they need to be on some form of antiplatelet agent. If you take them off everything, they're probably going to clot off their pipeline device, and they're probably going to have a massive stroke. So we put them on an eptifibatide infusion. We had them place the EVD, and we reloaded the patient with dual antiplatelets. So again, you're sort of tightening your sphincter to make sure that nothing happens. And so here you see their EVD. And we're monitoring our patient with TCD. So switching gears, as a very quick reminder, I know some of you attended our workshop earlier, but a very quick reminder what TCD is: non-invasive bedside portable monitor that allows you to assess cerebral hemodynamics. So it's not a vasospasm or stenosis detector. There's a lot of useful things that come from the monitoring of patients, and in particular is looking at the pulsatility indices. Now, I'm not at the point that I would say that you can calculate an ICP with a pulsatility index. However, what's quite useful for your patient is that monitoring the patient serially and paying attention to their pulsatility indices can help you guide your therapy, in particular with de-escalation of aggressive medical care. So here's a patient, vasospasm, treated with nimodipine, milrinone, for our friends from Montreal who love milrinone. We did use it in this patient. Treated with nimodipine, milrinone, and very mild induced hypertension. They also got intra-arterial verapamil. So here, by anybody's standard, 303 mean flow velocity and the right MCA is very significant vasospasm. Now, you do see there's concomitant hyperemia. So hyperemia refers to the, in this case, when you see that your end diastolic velocity is greater than half of your peak systolic velocity, there's a component of hyperemia in that. So I use the term diastolic thickness to refer to this component here. When you see your diastolic thickness is greater than 50% of the waveform, you know that it's not just vasospasm that's giving you that massively elevated mean flow velocity. It's also, there's an element of hyperemia. And here on the contralateral hemisphere, you have a very high mean flow velocity, and again in the basilar. Now, pay attention here to the pulsatility indices. Remember, your patient has an EVD, okay? So that means, and the ICP on the bedside monitor is normal. So here, our pulsatility indices are all normal: 0.6, 0.64, 0.62. So what you can do is you start weaning your EVD, and subsequently you look at your TCD and you try to make sure that the pulsatility indices didn't become ridiculously high. And that would be supportive evidence, because you can't get a CAT scan every minute on your patient. That would be supportive evidence that what you're doing in the weaning process of your EVD is safe for your patient. So here, the patient continued, fast forward, they had vasospasm for a substantive period of time. Here you see that their mean flow velocities have normalized, and the EVD has now been clamped for multiple days, and you see that their pulsatility indices still remain normal. So you can declare victory and take your EVD out. So I know it's a very broad subject matter, but thinking about neurosurgical complications, just think about them in terms of those groups that we talked about: the function of the pathology, the patient, and the surgical skill of the operator. Neuroimaging plays an integral role in the evaluation of these patients, and not just getting CAT scans on every patient. And consider the use of TCD for bedside hemodynamic information that can be used for serial monitoring of interventions aimed at ICP management. And I invite you all to attend the American Society of Neuroimaging course. There are several of you that attended our TCD workshop, a lot of enthusiasm towards the use of TCD, and we're going to be in lovely Puerto Rico, Martin Luther King weekend in January of 26, and I thank you for your attention.
Sounds nice. Thank you. Thank you, Ryan, and we appreciate all the visuals. And again, for all the questions, please save them. 2 more talks, and we'll be having a juicy discussion about all the talks we're going to have. So next, I have a pleasure to introduce our dear colleague, Abdullah. Abdullah is the director of ICU anesthesia in Oman and Khawla Hospital. They were kind enough to invite us last year. We did an ENS course in Oman, and they have quite a bit of interest in their ICU, and they're pushing the agenda forward and disseminating knowledge in ICU in Oman, and that's great to see. So Abdullah, the floor is yours. In a few seconds.
Thank you, Jamie, for
there you go.
Kind introduction. Good afternoon, everyone.
Abdullah, a bit closer to me.
Yeah. So thank you, Jamil, for your kind introduction, and good afternoon, everyone. It is my pleasure to be here and to have this talk. I disclose that I have no conflict of interest. And I will be talking mainly about the mechanical ventilation in acute brain injury. And this is one of the maybe controversial topics because we are lacking of enough evidence in this kind of population. Like recently, or maybe in 2020, has been the European Society have been published or have published kind of recommendations. So I will be taking you throughout my speech about the main recommendation from the European Society. First, severe acute brain injury or neuro critical patients usually need invasive mechanical ventilation, and this accounts for up to 25% of individuals receiving mechanical ventilations in ICUs. And as I said, that we have little data to inform the selection of ventilatory targets and strategies in this population, and this is mainly because this population have been excluded in most of the trials, and that's mainly in particular those patients with high ICP. So when we say about acute brain injury population, so usually we talk about patients with acute ischemic stroke, intracerebral hemorrhage, subarachnoid hemorrhage, traumatic brain injury, and patients with hypoxic encephalopathy. We have really there are unique clinical consideration in managing acute respiratory failure in this population, and that's mainly because of what we call the brain-lung crosstalk, and this is usually kind of dynamic and bidirectional kind of pathway. The optimal arterial blood gases targets in these patients may vary or may be different in this population, and that's mainly to optimize the ICP, cerebral perfusion, and the cerebral oxygen delivery. Again, can we implement the lung protective strategies in these patients? It might be harmful in this population, and when we take in consideration the high ICP patients. And as I said, we have uncertainty kind of data or trials when we come to that can guide us in liberation of ventilator liberation strategies. And when we decide about the ventilatory settings in these patients, and also when we decide about extubating or maybe tracheostomy in these patients. as I said, we are currently maybe focused mainly in the managing these patients and preventing the secondary brain injury, and also to optimize the oxygenation and the cerebral perfusion pressure in these kinds of patients. And it is thought that they are like kind of interaction between the lung and the brain, as we call it the lung-brain interaction. And this might be mediated by elevated ICP, neuroinflammatory markers, hormonal dysregulations, catecholamines, surge, and dysregulation of the central breathing control. And also in critically patients, other factors might also add on these factors like hypotension, drugs that we use in ICU, fever, and delirium. So, as I said, like the brain and lungs interact in a dynamic way, and it is usually like bidirectional. So hypoxemia and the inflammation may lead or may worsen the secondary brain injury, which is also on the other side that acute brain injury may worsen or may precipitate the lung injury through different pathophysiologies. And usually, like the most common pathophysiologies are the neurogenic pulmonary edema and ARDS. So if there's an increase in the ICP, that may lead to the catecholamines storm, which lead to the increase in the systemic, in the pulmonary and systemic vascular resistance, which may result in leaking of the pulmonary capillary and the neurogenic pulmonary edema. On the other side, again, as we said, the neuroinflammation or the neuroinflammatory physiology may precipitate lung injury ending into the ARDS. And it is clinically challenging maybe to distinguish between the neurogenic pulmonary edema and the ARDS, but ultimately the management might be the same. So, what are the ventilatory strategies in managing these kinds of patients? A recent consultant guidelines by the European Society emphasizes that the lack of evidence to guide ventilator management in acute brain injury, and in particular those patients with high ICP concurrently with ARDS. Now, when we come to the, can we use high flow in these patients or non-invasive ventilation? As we said, in these kinds, we have limited evidence, and there are no published RCTs on the use of NIV in these populations. But in some cases, we may use the NIV as a bridge to before intubating these patients, and mainly because most of these patients will be having compromised airway, and they would need intubation. So what about the ventilatory mode? Again, we don't have major trials that comparing the strategies, comparing the spontaneous and control modes. A control mode is beneficial maybe to achieve a specific PCO2 and pH, and those just to maintain or to when we want to control the ICP. And spontaneous modes can be used in patients with minimal oxygen requirements and intact respiratory drive. Again, then what are our goals in regards of the carbon dioxide and oxygen? So again, as per the European Society, they strongly recommend studies within PCO2 for 35 to 45 millimeter of mercury, for PO2 between 80 to 120. And as part of the tiered approach to treat elevated ICP, we may consider hyperventilation in some of these patients, lowering down PCO2 to 30 to 35. But again, it's maybe it's only considered in those patients who are with the risk of brain herniation. And we should take it selectively or individualize our cases case by case. Mild hypercapnia may be beneficial in optimizing cerebral blood flow and preventing maybe or minimizing the risk of DCI. And according to the recent TAME trial, sought to use the cerebral vasodilatory effect of hypercarbia to facilitate improved perfusion following cardiac arrest. They found there's no significant difference whether you go up with the CO2 or you with the tight control. The safety range of oxygenations in this population is still also uncertain, and recent research supports the need to consider the upper limit of oxygenation because of the acute, in those hypermetabolic kind of brain. And according to the central TPI, they showed that the median highest PO2 level during the first week after ICU admission may reach to 134 millimeter of mercury. And the maximal and mean PO2 were independently associated with unfavorable functional neurologic outcome or death at 6 months. In a post-hoc analysis of randomized trial, identified the PO2 thresholds of 150 to 200 may be associated with better functional outcome, whereas if you go more than 200 was associated with poor neurological outcome. So according to the European Society, they recommend a higher range of typical PO2 goals, as we said, from 80 to 120, taking in consideration these patients have a hypermetabolic kind of brain. And in those cases, it is recommended to monitor the brain tissue partial pressure of oxygen, but still this is under investigation. And several studies in traumatic brain injury and subarachnoid hemorrhage, they showed that there's an association between the mortality and the brain tissue PO2. And in Boots 2 trial, they suggested that the outcome benefits with the PO2 was, that there was a benefit from when we use like kind of directed therapy with the brain tissue oxygenation. And in Boost 3, it is an ongoing study, and they are studying the potential of ICP plus the brain tissue oxygenation, and to improve, just to look for if there's any kind of improvement in the GCS. And in a recently published study, TC trial, they didn't actually demonstrate any reduction of poor neurological outcome at 6 months when they were using just ICP compared when they used both ICP and brain tissue partial pressure of oxygen. So, as per the recommendation, as we said, the target of PO2 is between 80 to 120, and it is better also to assess the brain tissue oxygenation and to maintain it above 20. And in regards of the CO2, again, like to maintain it 35 to 45. And in cases where you need hyperventilation, you may come down to 32 to 35. So what about the tidal volume? Can we implement a protective lung strategy in these patients? So according to the ARMA trial, we know that the protective lung strategies should be considered in patients with ARDS and non-ARDS patients. But again, what about those patients with high ICP? Unfortunately, these patients with high ICP have been excluded from this trial. And as we know, a higher CO2 may exacerbate the ICP in these patients. So we have insufficient data in regards of using this, especially in patients with a high ICP. And according to the European guidelines, they strongly recommend the use of protective lung strategy in this population of patients, and in particular those patients with ARDS without a high ICP. But they are unable to correlate recommendation in patients with ARDS and high ICP. So we should weigh the risk and the benefits based on the oxygenation, lung compliance, and neurological examination for these patients with very good kind of monitoring of the ICP and PCO2. So as I said, the recommendation is to use the lung protective strategy and to avoid the hyperventilation and hypercarbia if in cases of high ICP. What about PEEP? We use PEEP titration to promote the alveolar expansion, optimize the lung recruitment, and enable more homogeneous kind of distribution of mechanical ventilations. But again, several RCTs showed, we know that it has shown improved oxygenation with higher PEEP strategies, but we know that also that the excessive PEEP can result in increased ICP, that by impeding the venous return through by increasing the intrathoracic and intra-abdominal pressure. So higher PEEP may also decrease the cerebral perfusion pressure due to the increase in the ICP, especially in those patients with impaired cerebral autoregulation. So the main mechanism resulting in the decrease in the cerebral perfusion pressure was found in this population might be due to the reduction in the mean arterial pressure. So by augmenting or by maintaining the mean arterial pressure, we might be able to maintain the cerebral perfusion pressure in these kinds of patients. So to date, there's insufficient data to predict the impact of PEEP titration on ICP and neurological outcome. So, and a better higher PEEP toleration in patients with intact cerebral autoregulation and preserved lung compliance. And it should be, considered with, in those patients that we need to monitor their ICP and map and prevent alveolar overdistension. Invasive and non-invasive techniques to monitor ICP should be considered in these patients, especially if you go with the higher PEEP more than 12. Again, for the plateau pressure, we don't have enough data, but as per the ARMAT trial, they demonstrated lower mortality and fewer mechanical ventilation days in patients when they use a plateau pressure of 25 to 30 compared to higher plateau pressure. So again, that's because mainly with the same mechanism that will lead to decrease in the cerebral perfusion pressure by decreased cerebral venous return. So until further, maybe there are ongoing trials or ongoing studies in regards of plateau pressure. So the recommendation is not to go more than 30 centimeters of water to prevent the induced lung injury. Driving pressure, which is the difference between the plateau pressure and PEEP. Again, we don't have enough data. And in one of the observational studies with around 980 patients with acute brain injury, it showed that the higher driving pressure was associated with increased risk of ARDS. And according to the TTM2 trial, they demonstrated there is an association between the driving pressure and as well as the neurologic outcome at 6 months in patients with both cardiac arrest encephalopathy. So the driving pressure can be modified gradually by titrating the tidal volume and PEEP, and while we should consider the ICP monitoring. So the recommendation is to maintain the driving pressure less than 15 and the plateau pressure is less than 30. So what about the mechanical power? Mechanical power, which is the total energy transferred from the ventilator to the respiratory system as per the respiratory cycle. And this mechanical power is usually derived from ventilator setting, from parameters of pressure, volume, flow, and respiratory rate. And according to a retrospective single study, it showed that there's an association between the mechanical power and the first 24 hours and ICU mortality. And in TTM2 trial, they demonstrated there is an association between this higher mechanical power, and mortality and neurological outcome. So the recommendation here also to use mechanical power of less than 17. So what about the rescue maneuvers in patients with ARDS and acute brain injury, like proning and use of ECMO? Again, we don't have enough data here. And as a recent systemic review summarizing these studies, it showed there's an increase in the ICB when a patient is prone. There was an increase in the ICB by 5 to 15 with the mixed effects and the cerebral perfusion pressure, but there will be all of that an improvement in the oxygenation. So the clinical relevance of these findings is not clear because of long-term outcomes were not reported. So proning should be strongly considered in these patients with moderate to severe ARDS, provided that you monitor the ICB and you have an active management if the ICB goes up. In regards of the ECMO, again, we don't have enough data. And especially like we know in ECMO that there are some relative contraindications, like by the use of the anticoagulations, that may increase the risk of hemorrhagic conversions, and also with the cannulation that also may decrease the cerebral venous return. And people also might be hesitant to use ECMO in these patients in considering the outcome for these patients. We always have these questions, when can we extubate these patients, or when can we trachea these patients? The optimal strategy to liberate patients with acute brain injury is still unknown, and we may take it like case by case. The rates of extubation failure within 2 to 7 days rank between 15 to 40%, and according to the ENEUS study, they found that 19% of patients required re-intubation within 5 days, and the extubation failure also ranged from 0 to 30% in different countries. And the extubation to the non-invasive devices didn't increase the extubation success, and around 20% of patients received tracheostomy without an extubation attempt. So the rates of tracheostomy are generally higher in the mechanically ventilated patients with acute brain injury compared to the other ICU patients. And according to one of the recent multicenter RCT in Germany and ICU, they found that no difference in the long-term neurological outcomes, mortality, and ICU stay between early versus the late tracheostomy. And 22% of these patients who were randomized for late tracheostomy ended up didn't really require tracheostomy and ended up with the tracheostomy. So with the extubation. So in summary, this is the recommendations as it is recommended by the European Society. And this might be taken as a guidelines for us when we consider mechanical ventilation in this population. So in conclusions, patients with severe acute brain injury have been excluded in most of the studies, and we don't have like kind of certain kind of guidelines, except by the European Society guidelines. Cerebral and pulmonary pathophysiology should be taken in consideration. Brain injured patients likely to require higher CO2 targets than other critically patients, and hyperoxemia should be considered, taken consideration the hypermetabolic brain in this population. Vigilant monitoring of ICP and PEEP when we are using a protective lung strategy, and especially those patients in prone and or when we consider ECMO. The ability to predict successful extubations in these populations remain a challenge, And there's no benefit of early versus or late tracheostomy in stroke, and maybe more data we need for in traumatic brain injury. These are my references. Thank you for your listening.
Thank you so much for that thorough review. We appreciate it. The take home from there is that last sentence, that we need more data. So for those of you that are researchers out there, it sounds like a call to arms. It's my sincere privilege to introduce to you Dr. Paul Vespa. He is an assistant dean of the Critical Care Medicine Research and Gary L. Branderson Family Chair in Neurocritical Care, and professor in residence of neurosurgery and neurology, and director of the Neurocritical Care Program. Dr. Vespa focuses on critical care for the treatment of neurosurgery and stroke patients. Dr. Vespa is a diplomat of the UCNS in neurocritical care and a diplomat of the American Board of Psychiatry and Neurology, and an immediate past president of the Neurocritical Care Society, and my friend. Please welcome Dr. Paul Vespa.
Thank you, Susan. Thank you, Susan. Today we're going to end the day by talking about coma. Hopefully not going to put you to sleep with that, but, and let's see, how does this go? How do we advance? Down? There? Okay. Okay, great. This one? Okay, now we're good. Okay, great. These are my conflicts of interest. I'd like to talk about differential diagnosis of coma, but really put this into sort of a practical approach to coma in the ICU, and talk about some of the common differential diagnoses, and talk about some of the tools that we have that we can use to sort of take actionable steps in addressing the coma. And we have a really great segue here, because we've talked about several of the things subsequently in these preliminary talks. You'll think that we really coordinated this really well, so that's great. So in the coma patient, one really does want to try to figure out whether or not they have a structural problem or they don't have a structural problem. Perhaps they have a metabolic or what we call a functional problem of the brain. And to do that, one needs to carefully assess the clinical examination of the patient, but also one needs to use technology to go beyond the clinical exam, because the clinical exam sometimes is not very forthcoming. If you look at the traditional differential diagnoses of all comers of coma in an ICU patient, this is roughly the breakdown that you'll see. And you see that hypoxic ischemic injury, shock, maybe that's the unresponsive patient to sepsis or septic shock or other forms of shock, make up large segments of that differential diagnosis, but also sort of a metabolic kind of event, hypoglycemia, renal insufficiency, liver insufficiency, etc. And these things do have a bearing on the differential diagnosis. However, in the more modern era now of critical care, especially with a growing population of interventions, such as patients on ECMO, patients with ARDS, with advanced therapy, what we're seeing is a different, more practical differential diagnosis. And we've talked about some of these things already today. Sepsis-associated encephalopathy, stroke and or hemorrhagic stroke on patients who have come in on ECMO or on ECMO. Seizures or status epilepticus playing a big role in a variety of disorders. And then complications of immune therapy or immunomodulation, because we're using that a lot in patients with advanced care. And then certain medications which may be toxic. You've already heard about cefepime. I'm glad I took that slide out of my set because others covered it. But other toxidromes that are very common. Toxidrome is a very common cause of encephalopathy and coma. But when we're looking at patients, what we try to do is go beyond the clinical exam. We use the Glasgow Coma Score, perhaps you use the 4 score, but you want to use some other technology. And we have point-of-care technology now that can really be used to elucidate what's happening inside the brain. If the brain is not just a black box, but we can get in there and try to look at things. And you've seen some of this already. I think it's very important to get a neuroimage of the patient who's in a coma. So if you're consulted or if you're encountered in your patient, gee, they have a coma, getting a neuroimage is really crucial. We've heard everything is a stroke alert or a stroke code stroke until proven otherwise. It's very true because you can use brain imaging to show ischemic stroke here. You can see a basilar artery stroke, a mass lesion such as a subdural, cerebral edema from hepatic encephalopathy, fulminant hepatic encephalopathy, or an ischemic stroke or other form of venous related stroke as well. And so getting that image will give you the first branch point in your evaluation. Do they have a structural lesion or not? If they do have a structural lesion, you have very clear-cut treatment interventions, strategies that you need to go through. So if they have a stroke, in this era, you're going to be thinking about thrombectomy, especially in a critical, let's say you have a post-operative patient who you were taking care of in the ICU with a stroke, acute stroke. You're not going to necessarily give that person a thrombolytic, but thrombectomy may be useful. A hemorrhage may need surgery. We heard about hydrocephalus just recently, and et cetera. So the images really do point us towards a specific treatment paradigm. Now, we've heard an excellent talk already on sepsis-associated encephalopathy, so we don't really have to go through that, but in terms of the pathophysiology. But the pathophysiology is sort of a neuroinflammatory or even infectious etiology inside of the brain, but it sets up the brain for a lot of different pathophysiological side effects. And in some ways, this is a very nice article. You've seen part of this article already. But this sort of calls forth patients who are being evaluated. You want to rule out other common things. But then you're going to take a look and you're going to evaluate whether or not they have focal abnormalities or whether or not they have infection and so forth. And you're going to dive deep into that evaluation. And then you're going to want to figure out if they're having seizures, because seizures are a very large proportion of patients with sepsis-associated encephalopathy. How many would say that seizures affect 5% of patients with sepsis? How many people would say that seizures affect about 20% of patients with sepsis? And that's what the literature shows. It's 1 in 5. It's very, very common. And then if you have persistent abnormalities, you're going to be sort of looking at other sort of secondary side effects, such as endocrinopathies that are associated with sepsis and hypotension and so forth, but also with brain dysfunction. Now, what's interesting is that we have tools to assess and interrogate the brain in real time. You heard a beautiful talk about transcranial Doppler ultrasound just now. Near-infrared spectroscopy is one of these non-invasive assessments of the brain that can monitor the brain, and it turns out it's probably one of the tools that can be used in sepsis-associated encephalopathy and in those patients who are in coma in the ICU. This is a tool that tells you what is the oxygen saturation of the brain blood vessels inside of the brain, at least at the surface of the brain. And these normal values are between about 60 and 80%. And if you have a drop in that number, then maybe you're having cerebral ischemia or lack of oxygen saturation in the brain. Number below 50% is a conservative number, or sometimes people say a drop of 10% to 20% below whatever your baseline was. This is something that's used frequently in the operating room. but it's becoming increasingly used in the ICU. I'm going to show you some data that suggests we should be thinking about using this in sepsis-associated encephalopathy. So this is a nice paper by Chiara Roba, where they use the near-infrared spectroscopy, and if it starts dropping, then what they do in sepsis is to sort of say, well, let's evaluate if the brain perfusion is too low. Let's raise the mean arterial blood pressure. Let's adjust the CO2. Let's adjust the PaO2, et cetera, et cetera. Maybe the patient's febrile and they're consuming too much oxygen. Maybe we need to lower the temperature in those patients. It gives you an approach to sort of evaluate the patient. Now, the other thing that happens is occurring is that you can actually evaluate what is your blood pressure that you should have. We heard a very nice talk about, well, blood pressure 65 to 80, it doesn't seem to matter very much in a population. But in the individual patient, autoregulation of the brain, that is preservation of blood flow based on different blood pressures, is disrupted in sepsis. And in fact, the mean arterial blood pressure needs to be maintained higher in some patients with sepsis with disrupted autoregulation. And this is a paper by the Hopkins group where they actually showed that pressure autoregulation is impaired. The figure B there shows a straight line, a correlation coefficient going upwards. That means that pressure autoregulation is impaired in that patient when you're monitoring near-infrared spectroscopy minute by minute, and you're correlating that with the mean arterial blood pressure. That is a patient that if the blood pressure falls too low, they may actually get cerebral ischemia. So in this patient with sepsis, where you're otherwise treating the infection and you're treating the ARDS, and you think MAP of 65 is fine, it may not be fine in that patient. And this is a tool that will let you dial in and become more precise with your therapy. This is the same paper where they're actually looking at, this is a patient where their near-infrared spectroscopy is fluctuating in sync with the blood pressure. The lower the blood pressure, the lower your brain oxygen. And they are not autoregulating very well. You can't tell if somebody's autoregulating in the brain just by doing the coma exam. That's not going to help you. The Glasgow Coma Score is not going to help you. You need a tool that's going to tell you, are they autoregulating or not? And this is a tool that's available, and this is sort of the frontier now of looking at sepsis. This is a large-scale repository of ICU data from the Mass General Hospital. It's called the MIMIC-4 database. 40 to 50,000 patients. And what these experimental scientists did was they looked at all patients who were septic and had septic encephalopathy, roughly 3,800 patients, and they looked at their mean arterial blood pressure and they correlated that with outcome. And what they found is that mean arterial blood pressure greater than, what was it, about 81.5 was the cut point. Below that, patients did worse. Above that, patients did better. So all comers, this is retrospective, this is not a randomized controlled trial, but this suggests that there's a relationship, perhaps, in some patients with mean arterial blood pressure. 65 may not be enough. What's another tool that we can use to look at patients and the clinical exam? The neuropupillary index, or the pupillometer. This is an automated way of looking at the pupillary light response. And this gives you a variety of measures, including what's called the neuropupillary index, and how brisk and how reactive the pupils are. But it gives you all of these other variables, the percent change, the maximum constriction velocity of the pupil, and it's quantitative, it's not qualitative with your pen light or your iPhone or whatever, but it's quantitative and it gives you a number. It turns out that this neuropupillary index is pretty important. It's important in traumatic brain injury, it's important in raised intracranial pressure, defining that. It turns out that in sepsis patients, the neuropupillary index less than 4 is associated with impaired autoregulation. And this is one of the studies looking at this assessment. So if you're looking at your patient in sepsis and you're using a pupillometer and they have impaired neuropupillary index, they may actually have impaired autoregulation. It turns out that over half of the patients have impaired autoregulation. Okay? So now, not just looking at the differential diagnosis, but actually now looking at how do you intervene, how do you assess that patient. And in fact, this is a same paper that looked at estimating that the intracranial pressure is actually elevated, again, using this neuropupillary index parameter. So when we look at, and you saw this table from just a few minutes ago, when you're looking at where should we keep the blood pressure, we have general parameters, but we have actually some specific monitors that may help us to actually fine-tune the treatment for these patients. And we have another tool that's in pretty much every ICU now, the bedside point-of-care ultrasound. And it turns out that this ultrasound that you use on the heart, you use on the venous access, you use it on other parts of the body, the lungs, can be used on the optic nerve sheath. And the optic nerve sheath diameter is a indicator, roughly, indicator of whether or not intracranial pressure is elevated. And it depends on how old you are and pediatric group or an adult group, but about 6 millimeters in adults, greater than 6 millimeters in adults, indicates elevated ICP, and you see the variables there for children of different ages. It turns out that sorry, this is going back, it's going the wrong direction, sorry. Turns out that the optic nerve sheath can be abnormal and is another indicator that maybe you have elevated ICP in a patient who's comatose. So if you're examining the patient, the image doesn't show you a stroke, bring over your optic nerve sheath. Do they have elevated ICP? It may be that there's something wrong with the brain that's causing elevated ICP, and that's why they're in coma. Seizures, brain electrical activity is very important and abnormal in patients who are in coma. It turns out that seizures is a big proportion of the problem across many different kinds of critical illness. And you can see here, hypoxic ischemic injury, cardiac arrest. Yes, they have cerebral edema. Yes, maybe they may need higher PaO2, lower PaO2, we don't really know. But their brain may be seizing a high percentage of the time. You're not going to see this clinically. Most of them, 80%, 85% of seizures are non-convulsive. You don't know they're there unless you're actually looking by EEG. And so it's a pretty high percentage, and it's higher probably in patients with brain hemorrhage, but the non-brain hemorrhage, but it's pretty high. It turns out it's pretty high in patients who have septic encephalopathy. And now it's been shown in multiple papers. The first one really that gets credit here is Dr. Odo and colleagues from Columbia, but others have actually demonstrated this as well, and they're pretty high incidence. And it turns out, if you look at a population of patients on a population level, which is what this study did, there's actually higher mortality independently associated with seizures and status epilepticus in the setting of sepsis. So it's not just an epiphenomenon of, well, they're sick and so they have a bunch of things wrong with them. This is probably enhancing their mortality in some way. After cardiac arrest, seizures are pretty common as well. I had in my slide around 20 to 33%. Slide earlier in the week had pediatric cardiac arrest. About 45% of those patients are actually seizing. But there's a number of articles, and the seizures can occur during hypothermia or even after hypothermia. And this is a nice paper in a pediatric presentation by Dr. Abend, where they actually seized more as they were rewarming. And so this is a whole concept that's evolution in our thinking. So treating those seizures after cardiac arrest are important. This is a paper called the Telstar study that looked at treating seizures and periodic discharges after status epilepticus. That was a negative study. It didn't show that it actually helped outcome. However, one of my colleagues pointed this out to me in a previous conference, this line here in red, and that is that all comers maybe didn't have an effect, but those patients who are actually seizing, not just having periodic discharges, when you treated those patients, they got better. So it's not, this is sort of sometimes falsely thought of as a negative study. Within there's a subgroup that actually did better. However, there's a big delay in starting the EEG. So what we've learned from these studies is that seizures happen, and they probably happen very quickly, and that we need to ramp up our timing in getting to the patient. Whoops, sorry. My slides tell me that I should be done, but okay, we heard about toxic metabolic encephalopathy. We heard about PRESS at a previous lecture, great lecture. The immune-compromised patients can be really a problem, but PRESS and other forms of infection, atypical infection, like fungal infection, can be a real problem in these patients who have some kind of immunosuppression, immunomodulation. And they can have opportunistic infections. And those patients who have CAR T cell therapy can get a very severe neurotoxicity syndrome that can include seizures and other problems. And those are independently treated by further immunomodulation, as you can see there. So there are many different sorts of causes of coma and encephalopathy in ICU patients. Many of these things are treatable and have complications that are treatable, but they require the use of technology. So coma is common. There's a lot of physiologic derangement, but that can be actually assessed by technology and treated therapeutically. And these are some of the main kinds of abnormalities that are present that can be treated, including impaired autoregulation. And brain monitoring is really important and needed to guide that therapy. So, and much of this is non-invasive, so you don't have to drill a hole in the head. And it's available. Point-of-care ultrasound is available in every ICU and can be implemented with training and education. Thank you, and that's the end of my talk.
Thank you, Paul. And so we have at least 5 minutes for a good discussion, so I urge everybody to hang around and collect your questions. I think there's a mic floating. The speakers are here, and we're gonna try to have a fruitful discussion. We have many, I think if collectively you take half of the audience, I think they are responsible for 90% of the guidelines and the literature behind what you see. So I'm gonna be calling upon all the leaders in the room as well to answer these questions. Anyone wants to start with any question? Because I have a burning one. Anyone has any question to start? We can distribute, bring you the mic. So I'll just go ahead and start, and if you have any questions, please do. So I think just for probably all the speakers, if you can, I have a question interesting based on the recent guidelines that, or consensus that was published in non-invasive monitoring. And I think all of you kind of touched upon non-invasive monitoring in different ways. I just was curious, and just a minute per speaker, what do you do in terms of evaluating coma? I mean, we're in a low-resourced area, and I'm in the UAE as well. There's not widely available continuous EEG and so on and so forth. What would you recommend for non-invasive, each of you, what would you do if you don't have the capability of continuous EEG? Do you do, say, in a suspected high ICP or coma, do you do optic nerve sheath, TCDs, or what are the combination that you would recommend to evaluate coma for various reasons, including high ICP? Maybe Ryan, you want to start?
Sure. So of course I'm biased. I would suggest TCD. I think what you're going to find with TCD, just think about it in the context of your ECMO patient. So your ECMO patient is sedated, laying there. They really can't travel. You know, how would you assess them? So the first thing you can do is evaluate somebody's pulsatility indices. Now, like I mentioned before, you can't use ICP. Yeah, I don't believe in using those formulas to get a numerical ICP.
what the test can tell you is that if the pulsatility indices are globally normal, then you do not have an ICP problem. If they are elevated, you may or may not have an ICP problem. In addition, you would also look at the, you can assess the cerebral perfusion by looking at that diastolic thickness, as I call it, to see if your end diastolic velocity is is greater than 10 centimeters per second or not. So that could help you guide your cerebral perfusion pressure and your MAP goals for that given patient. And then lastly, you can document that all the vessels are open. So those are the three very easy things that TCD can help you with.
Yeah. And maybe let me pause a common scenario that we face, like the liver failure patient that is comatose, coagulopathic. You want to take a decision, are they under high pressure, the CT is vague. What would you approach the patient? So TCD is one. What other things you would add or do to approach and give a proper management information or decision?
I mean, for sure, I mean, at this point, if we're talking about resource-limited regions, we had many of these conversations over the last 2 days. I mean, in that setting, for sure, needing to rule out any structural changes with imaging, that's probably available. Then it comes into looking more into that black box, as Dr. Fesba mentioned, and looking for the point of care at that point. If EEG is limited and we cannot rule out seizure, then checking the optic diameter for the size and MPI, that could be of help to look for the increased intracranial pressure, which is doable at the bedside as long as we have trained staff to do it, which we start doing more of that, because even in Boston, when we have all the resources, we have other regional hospitals that they don't have continuous EEG, and they have to refer back to us to downtown for this capacity. So, then we start really showing them and try to teach them on how to use point of care from that perspective. As Ryan mentioned, the TCD is a good tool too nowadays with MPI, especially now we developed our neurovascular unit to do more of that, and goes into what else in that black box from NIRS. We are still behind of performing more NIRS into our unit, but that's something becoming more convincing with the data that's showing up, and we are discussing that. So all these tools are available, assuming that we rule out structural and we take it from there.
I'm curious to see whether or not, are you all using less than 4 with your MPIs in an encephalopathic patient to indicate ICP elevation?
So the
Can you repeat the question?
So the question is, why don't you hand the mic down? The question is, what you're doing pupillometry, do you use the NPI less than 4 to indicate elevated ICP, or do you use another number? I think we use less than 4. It's debated as to how specific that is. It's sensitive. Is it specific? I don't know.
Yeah, we have been using less than 4 as a mark.
Do you use less than 3 for the other diagnoses? Is it just an encephalopathy?
Now we are applying it mostly for the encephalopathy part, so 4, but we have not lowered it more than that.
To go back to Jimmy's question, also, I think, if you're in a resource-limited setting, I think the point-of-care ultrasound you have for other reasons, so that's gonna be very useful for high ICP for you. I think if you don't have continuous EEG, you should be aware that there are several monitoring companies that make 2-channel EEG that you can put on. There's a couple out there that are displaying kind of thing, that's not the greatest thing necessarily. It's not the full diagnostic thing, but it's something, and I think that you can think about using that. You may be able to go, they may be using it in the operating room, and they may have that available for you, and that would be something to really consider if you don't have the full availability of continuous EEG.
Any questions? Rashid?
not working.
Rashid is a neurointensivist from Oman as well, a colleague of Abdullah.
While they're doing that, I'm wondering if any of you are using the non-invasive ICP monitor that's just coming out from South America.
We have not tried it yet.
Okay, I'll just go ahead. My question is for either Dr. Vespa or Dr. Hakimi about ONSD specifically. I noticed from my use and experimentation with this modality is that it's not that dynamic. It's reliable when it's positive if you use the appropriate threshold, but then when you try to repeat it, you don't see the same changes. Like I wonder, how dynamic is it in terms of repeatability? Do you see accurate and dynamic change in ICP reflected in the readings?
And maybe if you can comment on, Paul, like, do you take 3 readings each? Like, how would you approach the kind of your mini protocol of taking, how many readings do you take and the highest value and all that stuff? How would you?
Yeah, I think that's still evolving as to what the best methodology is. I mean, taking a couple of measurements per side to make sure that at each setting, to make sure that you're getting, you're not getting an aberrant number, you know, that it's reproducible at least that way. I think it's unknown how much it varies over time. I think that generally we, you know, just based on experience, we see that it's consistently high. It can go up or it can go down a little bit, but it's in that ballpark high. And I think that's relatively reliable. So one day it might be 0.63 and the next day it might be 0.66, but it's still in the abnormal range versus it's not fluctuating like abnormal to normal, at least in my experience.
Try that one. So we recently participated in publishing the consensus guidelines, myself and Dr. Sarwal. It's published in Journal of Critical Care. The historical studies have used different methodologies to measure the optic nerve sheath. And so a multidisciplinary international group got together and published those. So I would encourage you to look at that. And then about 2 weeks ago, we published in Journal of Vascular Ultrasound the sort of artifacts, the various artifacts. So I would encourage you to look at those 2 publications and to help guide you, because I think one of the major issues is that, let's imagine the 2 of us are on service following one another. You were measuring it by one methodology. I come on service, I measure it by a different methodology. And that's why the numbers don't make any sense. So across a given patient, when measured with the same methodology, I think it does fluctuate. It doesn't necessarily fluctuate minute by minute, but certainly as your intervention is entered or withdrawn, you will see variation that hopefully is actionable.
We have time for one more question, and then otherwise these speakers, I'm sure, will be more than happy to be available for you throughout the rest of the conference. Thank you very much for your time, and thank you very much to my esteemed colleagues that have done such a beautiful job overviewing for us. Thank you.
Thank you.
Thank you for having us.